When thinking about the best way to prescribe resistance training or strength training in this special population, oftentimes we'll use what's called the FIT equation, and that is a prescription that's based on the frequency of exercise, the intensity of the exercise, the type, and then the time or the duration of the exercise. So that makes up your acronym of FITT. So we'll talk through some of those pieces. So from a frequency perspective, you want to think about scheduling strengthening activities potentially opposite of more cardiovascular endurance activities. So usually an every other day scenario will work 2 to 3 times per week. So thinking about not overloading the system in any one day. That's really not any different than what you might think for any patient. From a scheduling perspective, for these patients, knowing that they may be less fatigued in the morning and their body temperature may be cooler in the morning, you may want to schedule or have them do their strengthening activities early on before they have any huge challenges with fatigue. There are certainly some considerations that we need to be mindful of in our patients with MS that potentially we're not as concerned about in other patient populations. And then you'll see that many of the constructs are the same. So we'll go through and we'll talk about that now. So when thinking about how to organize a strengthening and conditioning program, oftentimes we'll use prescription guidelines based on this FIT equation. So FIT is the frequency of the exercise, the intensity of that exercise, what type of exercise you're doing, and then the time or the duration of that exercise. So we'll go through and we'll talk about some of those factors. From a frequency perspective, this is no different than what you might give any other patient, in that we don't want to overload their system, their musculoskeletal system at any one time, and we need a day in between at least to allow for that recovery to occur so that the muscles can grow. So from a scheduling perspective, we're thinking 2 to 3 times a week so that it's balanced by days in which the patient might engage in more aerobic activity versus strength training activity. So kind of that every other day scenario. And then specifically with patients with MS, we know that fatigue is a challenge for them. So we might choose to schedule our therapy sessions in the morning or instruct them to perform their strengthening and conditioning activities in the morning before fatigue sets in. Because we know that fatigue is a challenge with these patients, you might need to limit the number of reps you have a patient do or break it up over the course of the day if that's helpful. You don't want to exercise the patient with MS to the point of fatigue. So they should feel tired, but not to the point where they need to necessarily lay down and take a nap after they're done with their morning exercises. So that's going to require that patient really tune in and you help them with that to what their body is telling them so that they can stop prior to getting to that point of fatigue. You'll want to design a program that slowly increases the intensity and the duration of the exercises that you're looking for your patients to do. So you may have to progress these exercises slower than you would for a patient without MS, because we know about their fatigue and we understand their disease process, but you're still looking to make improvements and increase that intensity for the patient. In terms of the types of exercise you'll do, you'll see listed below that any of the strengthening parameters that you currently know, using PNF, using MRP, closed chain exercises, targeting muscle groups that you know to be weak from your examination would be appropriate. And in a bit, we'll talk about some additional specific strengthening strategies that evidence has shown to be effective in these patients. Functional electrical stimulation, or FES, devices have been shown in the literature to be beneficial in strengthening for a lot of patient populations, including those with multiple sclerosis. And the way these devices work is that it sends a electrical charge or an electrical current to that muscle group to stimulate that specific muscle group. So in patients with MS, foot drop is a very common presentation that really impacts their daily ability to ambulate, their quality of life, and really increases their fall risk. So this would be a device, and you can see that on the picture to the right, that would be used either in conjunction with an orthosis or not, to be able to activate tibialis anterior to get the heel strike for gait. The video, if you want to watch it, if you're not familiar, shows one type of FES device. It's the walk aid on a patient with foot drop. So in the video, the patient is really exaggerating his knee flexion during the before video so that you could see what his ankle would do if he wasn't doing that. So you can see the level of foot drop. And then there's a after video that shows him with the device. It's only a minute or so long. As an aside, I do not work for walk aid. I'm getting no compensation from walk aid. I just happened to find this short video that demonstrated use of this device. Group exercise activities are a great way to get your patients with MS involved in exercise. In this specific area, because we have such a high prevalence of MS, there are several MS-related groups where just individuals with MS are doing circuit training or some sort of combination between circuit training and aerobic training to address their specific impairments as it relates to strength and conditioning. So those are always really great opportunities. It can help improve a patient's motivation, give them social support because there's other folks there who are going through potentially similar challenges that they're experiencing. So I've found that patients are more likely to stick with exercise that's done in groups, especially with individuals with the same or similar diagnoses. Gait training using the treadmill is also a really great way to strengthen and condition your patients with MS, and there's been a lot of research to support its use in this population. So you could think about all of the various gait deviations you might see. You could have foot drop or weak plantar flexors for push off, or more of a ataxic presentation, inconsistent step length, Trendelenburg signs. Any of those aspects can be addressed through treadmill training, especially if you're using some of the unweighted features at first before a patient's able to fully accept weight due to maybe fatigue or endurance. And the research has shown that use of the treadmill decreases a patient's fatigue and will increase their endurance and walking speed after some time. Whole body vibration platform training is an intervention strategy that has been gaining traction in the MS literature over the past, I would say, 5 to 7 years or so. It has been shown thus far to show improvements in strength, especially muscular endurance in patients with MS as it relates to translating into functional ambulation, so patients improving their muscular endurance to be able to ambulate more efficiently. There's also been research to support use of vibration platforms to improve strength in specific muscle groups. And you can do a variety of exercises using the platform. You could have your patients be performing squats, potentially lunges. You could have part of your body on the platform, part of it off. So there's really a lot of interesting and unique ideas that you can use to be able to integrate the platform training into your strengthening and conditioning protocol. The evidence, I would say there is evidence to support it, but there's also some evidence to suggest that we don't have all the information yet on this approach. So there is some literature to suggest that it wasn't any more effective than more of a traditional strength training approach, but certainly something to keep your eye on and an interesting way to address these impairments in these patients. Just a few points on strengthening in other systems that could be involved. So we talked earlier about respiration and the importance of measuring what your patient's capabilities are for respiration, because just like any other muscle, these muscles can be impacted in patients with MS. The same would go to for bowel and bladder strengthening. So you want to make sure if your patient presents with impairments in these systems that you address this through some sort of strengthening program that would target those specific systems. So just a few key takeaways before we move on to the next impairment that we'll address as it pertains to strength and conditioning. Strength training is a really important part of your patient's program with MS. And the key to being able to do this effectively and to actually be able to make gains without causing a lot of fatigue is to use that concept of intermittent training. So having the patient work for a period of time, rest, and then continue working, rest, and so forth. So that's really important, because if you don't do that, A, the patient's going to fatigue quickly, and B, the amount of repetitions that need to occur for strengthening and conditioning to actually happen is not going to happen if you're using one continuous period of time. So you definitely want to approach strength training from a discontinuous framework. And then the next piece is that it's a really exciting time, I've said that before, to be treating patients with MS, because now the research is conclusive that exercise is now neuroprotective and it's accepted as a disease-modifying treatment for patients with MS. Before this huge body of evidence came out, the only way we knew to control the disease process and to reduce the progression of the disease are through those pharmacological agents, those disease-modifying agents. But now we know that exercise and physical activity are associated with reduced relapse rates, reduced mobility, disability, and reduced progression of the disease process. We know that conditioning and strengthening are associated with decreased lesion volume. And there's a lot of evidence out there to show that walking outcomes have been improved by strengthening appropriate groups in the lower extremities. So this is a really important aspect of your patient's program. Next, we'll talk about balance and postural control and coordination for these patients. Now, we certainly understand that balance and postural control is not one standalone impairment. It is the contribution of many different systems, and you know this from our other coursework. So it's the vestibular system contributing, it's the visual system, the proprioceptive system. So lots of systems come together to allow the patient to have either appropriate balance and postural control or impairments in these activities and tasks. So in order to appropriately address that in intervention, you need to identify what area or areas are impaired in your examination to be able to then effectively address your patient's balance and postural control systems. Any activities that you might design for a patient with MS to target balance and postural control or coordination are really not any different than the activities that you would use to address these same impairments in other patient populations. So if the cerebellum is involved, we know we need to do activities to address coordination, and you have a large toolbox to be able to do that. Thinking about all of your different treatment approaches, PNF, NDT, MRP, you have skills in all of those areas. So there's nothing really new here to include on this slide as it pertains to the patient with MS, but I think it makes good sense if you think about the stages of motor control to start in those lower stages, making sure that the patient has the mobility and then the stability or the strength, and then move through those stages of motor control to address balance and coordination throughout positions that they're having functional challenges, and usually that would be sitting or standing. Another aspect to consider in terms of balance and postural control is to train patients under dual task conditions. So this could be a motor and a cognitive task, so the patient is ambulating while having a conversation, or they're ambulating while carrying a basket. That's also going to alter the sensory condition in terms of what the visual input is into the system. So coming up with different scenarios in which you're asking the patient to function under dual task will ultimately help reduce falls and improve balance and postural control. Over the past 4 to 5 years, there's been a body of evidence that has emerged to suggest that use of video games and virtual reality systems has improved balance and postural control in patients with MS, specifically anticipatory balance reactions. And this makes sense if we think about what type of feedback these video games often provide. If you've ever been on a Wii balance board, you know that as you're looking at the screen, you can tell whether or not you've made contact with the ball or whatever the game is that you're playing. So it's immediate feedback with a real world application, which would then improve the salience of that intervention strategy for the patient. Patients have also subjectively reported that they're more likely to comply and participate in balance and postural control exercises that are using these virtual reality and video game systems because they find it more entertaining and more motivating to use. Pain is another impairment that will likely need to be addressed in your patients with MS. And in order to be able to do this in a way that's effective as well as efficient is to figure out what the underlying cause of the pain is. So if it's related to the musculoskeletal system, is it a range of motion issue? Do they lack the range of motion? Are there contractures that have developed or are beginning to develop? Or is it something related to overuse? So we know that as patients begin to compensate for weakness, they may overuse other muscles to compensate for that in a pattern that's not biomechanically sound. So you have to be a bit of a sleuth in trying to figure out where the pain is coming from so that you can help in managing that pain appropriately. Your approach obviously would be different if it was contracture related versus an overuse injury or a compensatory movement strategy. Sometimes pain comes from psychological related issues or issues related to stress. So if that's the case, if you've ruled out these other areas, then certainly that could be a referral to a counselor or a psychologist to help manage the stress, or a social worker that can assist them in managing stress that's specifically related to the disease process itself and how it's impacting their life. So physical therapists certainly do play a role in pain management, but the key piece here is to figure out what is causing the pain so that you can really effectively address that issue. As a physical therapist working with these patients, you will have a lot of opportunity to integrate different types of cognitive training into patients' programs, depending on what their need is. So certainly dual task activities are beneficial to improve cognition and processing and to make motor plans more natural and more smooth. We've talked about that in terms of reducing fall risk, but it's also a way to challenge that individual's information processing and executive function. We often use mental rehearsal during treatment, especially in patients with MS. If you think back to our previous discussion regarding affording these patients opportunities to rest, so scheduling an activity in an intermittent fashion, that's the perfect opportunity to allow a patient to practice mental rehearsal when their body is physically resting. So you would ask them to envision either what they previously engaged in, if you had given them some feedback on what you wanted them to work on, or potentially the next upcoming intervention strategy. So use of mental rehearsal is quite beneficial in terms of motor learning or motor relearning for patients with MS. The following bullets discuss more compensatory strategies. So depending on what challenges the patient presents with, certain memory aids may be helpful. There's apps that you can download on your phone that will alert patients to activities that they need to participate in, appointments they need to attend, taking medication, so on and so forth. Timing devices, environmental strategies that you can use throughout the home, whiteboards, labeling, pill containers using different colors, marking the stairs if patients have challenges with depth perception. So there's a lot of different compensatory strategies that could be put into place to help a patient who has deficits in cognition. Depending on your patient and the nature of their disease progression, you may be involved in recommending orthotics or assisted devices to help patients with their safety and with their functional mobility skills. So we've talked previously about AFOs and KAFOs. You could combine those with functional electrical stimulation devices. And really that is very specific to the patient and the patient's needs. You have to weigh the risk to benefit ratio of a recommendation such as this, because as I said in the examination PowerPoint, you will decrease a patient's proprioception by putting an orthotic device on them. So if they're really relying on proprioception, or if they have deficits in proprioception already, it may make that patient more unsafe. The AFO could also potentially, and KAFO, add to the weight of the limb, which then costs more energy, and the patient may fatigue earlier. So you have to kind of weigh the pros and the cons of using such equipment and see what's the best scenario for the patient. I will say with the functional electrical stimulation devices, they're very effective, but they're extremely expensive, and insurance companies typically don't pay very much towards these devices. So some companies will allow patients to take out a loan, almost like a car payment for the functional electrical stimulation devices, but they can be anywhere between $7,000 and $10,000. So it certainly is a costly endeavor that the patient would probably need to be prepared to pay for out of pocket. You may find you're making recommendations for patients to use assisted devices during ambulation, and they may use more than one assisted device. So you might have a scenario where a patient is able to ambulate safely and efficiently with a cane within their home or in short distances, but then when they go out into the community, they need a walker or potentially even a scooter or manual wheelchair. You may have a patient who is already using an assisted device, but it's just not the most appropriate assisted device. So perhaps the patient's using a cane, but they have a lot of ataxic type qualities and challenges with coordination, and maybe it's a safety issue for them to be using a cane. So you'll be responsible for evaluating that and then making those appropriate recommendations. And then certainly any wheelchair considerations. So we know we have both manual and power options, and that really is dependent on where that patient is in the disease process, and then you have to try to prognosticate where they're going to be. Do they have a more progressive type of MS where eventually you're thinking they're going to need a power wheelchair? So those are considerations that you have to think about before embarking on obtaining a wheelchair device. Part of being able to effectively treat patients with MS is being able to assist in the psychosocial management of what these patients are experiencing. So you might be thinking that is perhaps outside the scope of what we're trained to do, but it is certainly a vital part of what you will need to be able to manage to some extent in a patient with MS. So we've been saying all along that every patient's presentation is different. And that is true. And every individual has different strategies to deal with what is happening to them and what's occurring in their disease process. From my personal experience, one of the most challenging things for patients to deal with who have MS is this feeling of unknown, this uncertainty, inability to predict what's going to happen with the course of the disease progression. And that could be very small scale on a day-to-day basis. So trying to make plans with friends and family, and you're not feeling up to it, you're too fatigued, you overdid it that day, whatever the case may be. Not being able to keep up with some of the activities that their peers or their colleagues are doing. So there's a lot of challenges as it surrounds the psychosocial aspect. Patients may be experiencing a steady decline, and they recognize that, and they're grieving the function that they did have. So depending on the nature of the progression, how long the patient's been dealing with this, will kind of dictate what needs to be done from a psychosocial perspective. Certainly, you want to do the best you can to improve a patient's self-efficacy, so that feeling that they will be able to manage whatever comes up, and give them the resources and the referrals to be able to do that, teaching them strategies that will assist in that process. And then referrals to individuals who specialize in these sorts of challenges, a psychologist perhaps, or a social worker, or support groups. There are a lot of support groups for patients with MS, especially in this area, can really all help assist the patient in developing skills and strategies that are healthy to be able to deal with the feelings that they're trying to process. As you treat your patients with MS, you will be doing quite a bit of patient and family education. You'd be surprised at the number of individuals who really don't have a good handle on their disease process, what it means, what to expect, because their neurologist or their diagnosing physician hasn't had the time or taken the time to really explain that to the patient. So a lot of your education initially may be to just educate about the actual disease process itself. One of the best gifts you can give your patients is to teach them and encourage them to find this balance between giving them the tools they need to be successful, so that they can feel empowered, and that they can, that there is a lot of things they can do to slow this disease process down, to decrease the rate of relapse, and all of the aspects we've talked about throughout this lecture, to be able to balance that empowerment with realism. So making sure that they are realistic in what goals they're setting for themselves and where they see themselves going. So it's a really, you have to strike that balance between giving your patients the tools they need to be successful, and then also creating realistic goals for your patients. You will also be providing continuing education on energy conservation and activity pacing that we've talked about in previous slides. How to negotiate the healthcare system, how to get pieces of equipment approved, how to get reimbursement from your HMO, how to basically play the healthcare game. So being able to be an advocate for yourself, request imaging when needed. Those aspects are really valuable to be able to provide that education to your patients. You want to stress upon the importance of health and wellness, and we've talked about that, and we'll end this lecture with some of those pieces. And then give them the community resources that they feel that they need to feel that they're being heard, that they have people that are going through similar experiences. No matter how well versed you are in the disease process, or how many patients you've treated who have MS, you won't truly be able to know what they're feeling and what they're experiencing, because it's not happening to you. So you can be empathetic, but really a gift you can give them is to hook them up with other patients who, and other resources where they have people that they can talk to who understand what the day-to-day is like. The reason we can make progress with our patients with MS during intervention is because of the concept of plasticity, and we've talked about this so many times throughout the past 2 semesters. So we won't get too much into plasticity or what that means, because I know you know that. Maladaptive plasticity is kind of the converse of that. So just the same way that you can make improvements in patients with MS who've experienced exacerbations or a steady decline can experience maladaptive plasticity, where it's almost like that learned disuse thought process. So some disability that is seen in patients with MS might not be because of the actual disease process, but because they're not practicing and using all the systems that they should be using. And then you will see changes in cortical mapping and maladaptive plasticity occurring. So you have the patient who is becoming more and more immobile, and they're not performing their ADLs or their functional mobility tasks, and they're not using the modalities or the systems that they should be. And that's when you start to see some of those maladaptive changes in the nervous system. And that's a cycle. So that's why I have that picture down there. That's kind of a catch-22. You're immobile, you have maladaptive changes. Those changes then encourage you to experience further progression of disease process and further symptomology, and then that cycle continues. So how do you break that cycle in patients with MS who have so many systems involved and experience so much fatigue? So we know that in order for plasticity to occur and for those long-term changes at the cortical map level, we need to have the patient engaged in functional activities at a very high volume with a lot of repetition. So these are not new concepts we're talking about. We've talked a lot about how to encourage repetition throughout the course of the day for patients of varying diagnosis with neurological impairment. So that thought process is still the same. We need to get that volume, but now we have this challenge with patients with MS, and we can't treat them the same way that we might treat a patient who's had a stroke or even a patient with Parkinson's, because it's not the same disease process. So we have this problem, so to speak, with patients with MS, this dosing problem. How do we get those repetitions in so that learning can occur and so that real plastic changes can occur? So how do we solve this volume problem? And really the answers lie in using intermittent training and keeping the patient cool so that they're able to perform a higher level of work before that fatigue sets in. And then, of course, you need to address their underlying impairments, what is contributing to their functional impairments as it pertains to strength, balance, and postural control. So the evidence over the past 3 or 4 years has really demonstrated that use of intermittent training not only helps solve this volume or this dosing problem that we have in patients with MS, but the patients feel better, they have less fatigue, they're more empowered to continue on, and then we're seeing improvements in function. So distance ambulated, strength, and then quality of life as well. So use of intermittent training has been demonstrated to be effective in patients with MS. We all know how to do intermittent training, but how do we know when to give the patient a break or when to stop? And this is really tricky, and it's not the same for each patient. So some patients are really good about recognizing what their triggers are, their symptomology, when it's time to take a break, and adhering to that. Some patients recognize it, but they don't want to adhere to it, and they want to be a warrior, and they push through that. Some patients might be new with this disease process, and they don't have that knowledge yet because they haven't had enough experience and enough time with their symptoms to be able to determine when they need to take breaks. So that's going to be you and the patient working, and certainly your observation skills of their face, of their breathing pattern, of their vital signs, asking them how they feel. And then ultimately, to be conservative, if you're really not sure, then you would just impose a break on a patient. So have them sit down, explain the next activity, use the mental rehearsal. Any one of those things can help you with that. So, over time, you'll gain experience that will help you cue into that when the patient's not able to do so. There are several different ways that you can keep the patient cool during therapy to allow you to train harder and longer. There are cooling vests that patients wear, and we have a cooling vest that we can use during clinics with our patients. So that will decrease their core body temperature, and in theory help prevent that heat from building up to maintain that nerve conduction. So you could also, consider lowering the temperature in the room, opening a window if you're in a cooler outside environment, offering the patient something cold to drink. Cooling towels have been used to kind of keep this heat down, but that's really important because it's going to prolong how long the patient can work if they're working from a baseline that's cooler than typical. So just to sum this lecture up for patients with MS, in applying the principles of neuroplasticity, I'll quickly reference back to the Klein principles. So I'm fairly certain that you heard of these principles before in motor control and motor learning, and they hold very true for a patient with MS. And I've put what I think are the really important principles of neuroplasticity for these patients in red. And it really makes good sense when you read through those and you think about what you know about learning and under what conditions learning will best happen. So I think it makes good sense to think that you get bad at what you don't practice, right? So that's that use it or lose it. And you get good at what you do practice. So if you use it, you're going to improve it. Practice what you want to improve. That's that specificity of training. So what do you want to do? Practice that. That repetition matters. You got to practice a lot, and the intensity matters. You have to get these patients to a point where they're practicing fairly hard. Obviously not to the point where they're so fatigued they're going to have a pseudo exacerbation or worse, a full-blown exacerbation, but you have to get to an intensity where those plastic changes can occur. And then salience matters. You practice what's important to you, right? So that's where the therapist and the patient need to collaborate to come up with goals and outcomes that matter to the patient and that are in line with what the therapist thinks needs to be addressed. So I think when you kind of look at that as a whole, these principles of neuroplasticity make really good sense as we apply them to patients with MS in our interventions.